Our first speaker is Professor Peter de Cruz. So Professor Peter de Cruz undertook his PhD in IBD at St Vincent's Hospital in Melbourne before spending time in the UK at Addenbrooke Hospital and St Mark's Hospital. He's been the director of the IBD service at Austin Health since 2014 and professor at University of Melbourne. He's actively involved in research and leads research teams here at the Austin, running many clinical trials in various facets of IBD. His work has been published in numerous peer-reviewed journals over the years, as well as having a number of book chapters and a book as well. So working at the same facility as the Victorian Liver Transplant Centre, Peter and his team work closely with PSC patients who have IBD both pre and post-transplant. Peter speaks both nationally and internationally on key IBD topics, and this evening is bringing his particular expertise on PSC IBD to us. So we're very fortunate to have Professor de Cruz here, and I will hand over to him. Thank you.
Thanks very much, Travis, for that warm welcome, and a big shout out also to Kerry Goldsmith from PSC Support Australia for the invitation to speak to you today. And a big shout out also to PSC Support Australia for all the wonderful work that you do. So I'm very mindful that I'm speaking to a mixed audience. So if at any stage you've got any questions about what I'll be discussing today, please feel free to put them into the chat, and I'm sure that Kerry will actually direct them towards me so I can try and iron out any clarification that's required. So today I'm going to take you through an overview of the relationship between IBD and PSC, discuss some of the impact of medical as well as surgical management on disease course, and take you through the risk of bowel cancer and the need for monitoring. So first of all, how are IBD and PSC connected? Well, the honest truth is that we don't know whether these are actually both part of the one condition or are actually two separate conditions that are actually interrelated. But what we do know is that 1 to 8% of individuals with IBD have PSC. So the majority of patients with inflammatory bowel disease don't have PSC, but 1 to 8% of them do. In contrast, if you look at PSC alone, 70 to 80% of individuals with PSC will also have ulcerative colitis. And about 15% of those individuals with PSC have Crohn's disease. And about 5% of individuals with PSC have indeterminate colitis. So it's safe to say that if you have PSC, there's a good chance that you'll also have some form of inflammatory bowel disease. IBD is actually mostly diagnosed before the diagnosis of PSC, but it can be diagnosed after the PSC diagnosis and even after liver transplantation. And so I guess the frequency with which inflammatory bowel disease occurs in PSC is supportive of both of them actually being part of the one disease. Now, the reality is for PSC is that by the time it's actually diagnosed, it's often in a very advanced stage, by which I mean that there's significant scarring or fibrosis of the bile ducts, and therefore the disease is advanced. In order to actually try and find out what the actual cause of a disease is, we really need to know about disease that's early in the disease course. As a consequence of this, most of the data that we have available to us are very sparse, and therefore it's a lot of our understanding of the underlying cause is actually conflicted by what we call the chicken and egg conundrum. And what I mean by that is that we don't know whether the first thing that causes PSC to develop is actually an imbalance in the good versus bad bacteria, or whether it's the immune system or vice versa. But what we do know is that there is a relationship between the gut and the liver, and this gut-liver axis is disrupted in PSC. And there are sort of four major hypotheses as to why it is that this condition develops. And I'm going to spend a little bit of time on this slide to try and provide some clarity around those four major hypotheses. The first is that there is this concept of dysbiosis. What do I mean by that? Well, dysbiosis refers to the imbalance between the pro versus the anti-inflammatory bacteria in the gut. In other words, an imbalance between the good versus the bad bacteria. And what actually happens as a result of this imbalance between the good versus bad bacteria is that they can actually cause a direct problem in terms of damage, or they can actually produce toxins, the bad bacteria that is, and these toxins travel via the portal vein, which drains the gut and takes these toxins directly to the liver. And these toxins can actually produce a bile duct injury, which is characteristic of PSC. So that's the first hypothesis. The second hypothesis is that there's the leaky gut phenomenon. And basically what that refers to is that there's a disruption in the normal integrity of the gut as a result of inflammation within the bowel. And that leads to an increase in influx of those bad bacteria, again, via this portal system or portal vein to the liver, to again cause issues with the bile ducts. In addition to that, there is a problem with altered bile acid signaling. Now, what does bile do? Well, first of all, bile is produced by the liver as a digestive enzyme, and it's very important for digestion. But the downside to the bile is that in high levels, it can cause toxicity. And that's actually thought to be the case in IBD, where there's this abnormal signaling, particularly in the right side of the colon. So what tends to happen is that there's a feedback process, and if there's too much bile in the right side of the gut, then it sends signals back to the liver to reduce the amount of bile production. But the problem with inflammatory bowel disease is that that actual signaling is disrupted, as a consequence of which toxic levels of bile build up in the liver, causing bile duct injury. And the last hypothesis really pertains to the immune system. And what that basically means is that there's immature white cells which are primed by the gut's immune system. And rather like the concept or analogy of homing pigeons, what it does is the gut immune system sends these homing pigeon white cells to both the gut and the liver. And that actually launches an immune attack on both the gut and the liver. So they're the four major hypotheses related to the gut-liver axis in PSC, the imbalance between the good and versus bad bacteria, the leaky gut, altered bile signaling, as well as this abnormal lymphocyte or white cell trafficking. Now, I've spoken about the imbalance between the good versus bad bacteria, and I've spoken about the immune system, but what about genetics? Well, we know that PSC prevalence is actually increased tenfold in patients who have a first-degree relative. So if you've got PSC, there's a tenfold chance that someone in your immediate family is also going to have PSC. We also know that PSC and IBD share some susceptibility genes with autoimmune diseases. So there is considerable overlap between PSC, IBD, as well as the genes that are related to type 1 diabetes, rheumatoid arthritis, and celiac disease. But that being said, even though there's this shared overlap between these autoimmune conditions, only half of PSC-associated genes are also affected in IBD. So whilst there is some relationship between the two conditions genetically, there's only limited overlap between PSC and IBD as well as an IBD, which is more supportive of the theory of them being two separate conditions that have some overlap. Now, is IBD with PSC the same disease as IBD alone? Well, I can tell you now that the two conditions do present somewhat differently. In patients who have got both IBD and PSC, they're more likely to have the whole of the bowel involved, which we call pancolitis. They often have a predilection towards developing more severe disease on the right side of the bowel. And many patients actually have sparing of the rectum. In addition to that, we know that patients with IBD and PSC have an increased risk of colorectal neoplasia. Now, neoplasia refers to both precancerous changes in the bowel as well as cancer itself. In addition to that, although there are these things that are sort of less favourable, we do tend to see that patients with IBD and PSC tend to have milder symptoms and possibly milder disease activity overall, and tend to have milder histologic inflammation. So, in other words, PSC and IBD has a unique clinical presentation compared to inflammatory bowel disease alone. Many of you might wonder, how does PSC actually influence inflammatory bowel disease? When we compare PSC alone to patients with both PSC and IBD, what we know is that there's an increased likelihood of both disease within the liver and disease outside of the liver. So this is a schematic that shows what we often see in PSC, which is these beading of the ducts that's actually developed as a result of injury to the bile ducts. It produces this beading sort of appearance. Now, patients with IBD and PSC also have involvement of these ducts outside of the liver, or more likely to do so. We also know that PSC and IBD are more likely to require liver transplantation. So how does inflammatory bowel disease influence PSC? Well, the first thing to say is that the data in this area are limited, but there is this possible kind of unusual inverse relationship in inflammatory bowel disease activity and the severity of PSC. In that, what we have noticed is that those undergoing liver transplant, and this was demonstrated in a single series, were more likely to have a milder course of their inflammatory bowel disease than those who didn't undergo liver transplant. That said, in the same study, those who didn't undergo liver transplant were more likely to develop colorectal neoplasia, either precancerous change or bowel cancer, or require intestinal surgery. But again, I must reiterate, the data are limited, and the data on the impact of IBD activity on the progression of PSC are scarce and much needed. What about the impact of therapies for IBD in PSC? Well, I'm sorry to say that none of the therapies that we have that are effective in IBD work in PSC. Antibiotics have not been demonstrated to be effective in ulcerative colitis, but may be of some benefit in PSC. Sulfasalazine, but not mesalazine, may be beneficial, and a trial is currently underway to try and evaluate this further. Data regarding the immunomodulator azathioprine on the risk of liver transplant and mortality are conflicting, and there doesn't appear to be any benefit to PSC for the standard biologics infliximab, adalimumab, or vedolizumab. Now, we looked at biologics, which are our magic bullet in inflammatory bowel disease, in more detail by undertaking a systematic review and meta-analysis of six studies, including 411 patients. And really the upshot of our research into this area was that if one is treated with vedolizumab, infliximab, and adalimumab and had that combined PSC IBD, it wasn't associated with any improvement in the liver function test. It was nonetheless effective in treating the colitis associated with PSC. And the biologic vedolizumab was associated with a worsening of the liver function tests compared to other biologics. So this is a bit of an area that really requires further exploration, and in particular, the effect of vedolizumab on liver function tests and creating abnormalities warrants further study. What about if you have your bowel out in the setting of PSC IBD? Well, again, the data on the impact of colectomy are variable. And this really comes down to the individual countries in which these data are from. In data from Sweden, undergoing a colectomy versus not undergoing a colectomy, in other words, keeping a colon, did not appear to affect the risk of developing PSC in ulcerative colitis. The effect of colectomy on liver transplant-free survival, in other words, actually surviving without a liver transplant or staving off a liver transplant, also appears variable. The ability to actually maintain liver transplant-free survival was increased amongst those who went colectomy, provided it was prior to, but not after, the diagnosis of their PSC, compared to those who kept their colons intact. That's from a Swedish study. But in a different study from the Netherlands, liver transplant survival was only increased provided that the patients not only had their large bowel removed, but also their rectums removed with a permanent stoma bag compared to any other form of colectomy. So in terms of trying to draw these data together, I have to say that the effect of colectomy or removal of the bowel on PSC before liver transplant is controversial. And one wouldn't recommend necessarily having one's bowel out just to actually stave off liver transplant. It needs to be an individualised choice based on the merits of risk versus benefit. Now, Kerry asked me to speak specifically on PSC-associated pouchitis. And this is a unique clinical condition with an increased risk of any type of pouchitis or inflammation of the pouch, chronic pouchitis, where patients are either dependent on antibiotics or have treatment that is refractory or not responsive to antibiotics, as well as pouch failure, where the pouch doesn't really work in a functional way at all. And you can see that sadly, the odds are stacked against PSC in terms of increasing the risk of pouchitis. So what do I mean by PSC-associated pouchitis in terms of how it presents? Well, it's characterised by moderate to severe pouch inflammation, pre-pouch ileitis, in other words, involvement of the small intestine high up within the pouch, reduced response to conventional antibiotics, as well as the frequent need for long-term antibiotics and or immunosuppressive treatment. And so I think that the take-home message here is that patients with PSC should really be counselled regarding the increased risk of chronic pouchitis before undergoing pouch surgery, because quality of life might well be better in those who actually elect not to proceed to pouch surgery. So what is the course then of IBD post-liver transplant for PSC? Well, again, the data are inconsistent here with series reporting either increased or decreased inflammatory bowel disease activity after liver transplant. But what we do know is that around 16% of patients with IBD PSC have more than one exacerbation of their IBD post-liver transplant, and that occurs within a median of 5.7 years. De novo IBD, or in other words, newly diagnosed IBD, can occur in up to 18% of patients within 10 years post-liver transplant, especially amongst those who are on a background immunosuppression of tacrolimus and mycophenolate, compared to those on cyclosporin and azathioprine. We know that the risk of graft failure has also increased tenfold in those of active IBD compared to inactive IBD, and that IBD itself is an independent risk factor for the development of recurrent PSC within the graft. Now, these are data that we actually looked at in the Austin itself in relation to the activity of IBD after liver transplant. And what we found was that it actually did predict poorer outcomes. So that compared to patients with mild IBD, those patients with moderate to severe IBD had poorer outcomes with increased rates of acute cholangitis, in other words, inflammation of the bile ducts in the liver, increased risk of colectomy rates and an increased chance of bowel cancer or high-grade dysplasia, in other words, high-grade precancerous change, an increased risk of strictures or narrowings within the bile ducts, and recurrence of their PSC after liver transplant. And so that really speaks to the fact that we do need to take an active monitoring and tight control of patients' IBD because it seems to be important in terms of reducing the risk of these outcomes. One of the things that we also were curious about was, the impact of biologic treatments and advanced therapies amongst those who are already on immunosuppression for their liver transplants. And because we really didn't want to be trying to add insult to injury when patients are already on immunosuppressant medications for their liver transplant. And so we looked at the outcomes of 36 patients from Victoria and New South Wales, and 89% of these patients had PSC, and 72% of the patients had ulcerative colitis. And they were exposed to about 59 months worth of biologics therapy. And we looked at the incidence of adverse safety events, such as infections and so on. And the incidence of these actual adverse safety events were comparable between those who actually were on gut-selective biologics like vedolizumab compared to the more systemic biologics such as infliximab and adalimumab, as well as ustekinumab. What we found was that the main risk factor associated with bad outcomes was the amount that patients were exposed to steroids, as it was the only non-biologic immunosuppression that was associated with an increased risk of adverse safety events. So what we concluded was that biologic choice should not be influenced by concerns regarding co-prescription with post-transplant immunosuppression, and really needs to be introduced in an individualized way to each individual patient. What about the new kids on the block with JAK inhibitors in ulcerative colitis PSC post-transplant? These are also data that have come out of the Austin, as well as New South Wales and Tasmania. This is the largest series, would you believe, of only 8 patients internationally who were exposed to JAKs for a median of 17 months, a whole combined 143 months of follow-up. Tacrolimus was the anti-rejection agent used in all patients, and these were patients who had actually failed 1 or more biologics, and 6 out of the 7 had actually failed 2 or more biologics prior to JAK inhibitors. 7 out of these 8 patients achieved clinical remission, including 3 who had switched from tofacitinib to upadacitinib, and only 1 of the patients required colectomy a month after treatment. Quite reassuringly, even though this is a small series, there was no cases of serious infection nor venous thromboembolism, in other words, clots in the legs or the lungs, or major adverse cardiovascular events. So it appears that combining JAK inhibitors and transplant anti-rejection medication may be safe and clinically effective in patients with prior biologic failure. But this is a small series, and we need to actually look at larger series in the future to substantiate this approach. Now I'm going to switch tack now to manipulation of the gut microbiome in inflammatory bowel disease and remind you of dysbiosis, which I referred to as the imbalance between the pro versus anti-inflammatory bacteria and versus, in other words, the good versus bad bugs. And this has been demonstrated to be an issue in inflammatory bowel disease, especially in Crohn's disease, and tends to be exacerbated by smoking and Crohn's. Now, I'm going to use the analogy of what's called restoration ecology. And if you look at the lawn in your own backyards, the flourishing gut ecosystem would look nice and healthy, like the picture there on the left. Now, what we do see is that whilst antibiotics can be helpful in some cases, they can also create devastation and eradication of that nice, healthy lawn. And if left alone without TLC, the weeds can develop and those species run wild. So how about if we were to take the approach of trying to bypass the weeds to replenish the ecosystem? Well, that can be done in a number of ways. First, using probiotics, which are live bacteria in small amounts, or we can actually give the bacteria food to flourish, or we can actually change the lawn altogether by rolling out new lawn, which is called bacteriotherapy or microbiota transplantation, in order to restore the ecosystem back to nice, healthy lawn. So let's look at antibiotics in more detail. Well, there's been a number that have been evaluated in PSC IBD, including vancomycin, metronidazole, rifaximin, and minocycline, and azithromycin, and they've all been evaluated in PSC. And what we know is that both vancomycin and metronidazole improve liver function tests in many studies, but their impact on preventing disease progression in PSC is unknown. In PSC IBD, vancomycin has been the most widely studied antibiotic and has been associated with a clinical response and remission in about half of patients. But really what we need is randomized controlled trials to confirm the dosing, duration, efficacy, and safety of vancomycin before it can be routinely prescribed. How about probiotics, prebiotics, and postbiotics? Well, probiotics are the only ones that really have been evaluated in this PSC setting. And these are live organisms that confer health benefits. And in one randomized controlled trial, including a combination of lactobacillus and bifidobacterium, there was no improvement in symptoms or liver function test. Untested compounds include prebiotics, which are food for the bacteria, or postbiotics, which are bioactives that are actually produced by the microbiota. So this remains a watch that space. Many of you might have heard of fecal microbiota transplantation. What is that exactly? Well, that's where stool is given from a healthy donor to a recipient to help treat disease. Donors are actually screened for numerous infectious diseases, and stool is processed and filtered prior to delivery via either a colonoscopy, an enema, or oral capsules known as the crapsule. These are highly effective for the condition of recurrent Clostridioides difficile or C. diff colitis, and they're also effective at inducing remission in ulcerative colitis, but not Crohn's disease. What about FMT in PSC IBD? Well, there's been one study that looked at 10 patients, all with IBD, and a single 90 mils of FMT from a single donor was administered via colonoscopy. And 3 out of the 10 patients had a more than 50% decrease in their alkaline phosphatase, which is one of the liver enzymes. And that alkaline phosphatase decrease was associated with engraftment, where the actual donor stool took hold of the recipient of several donor-derived microbes. Unfortunately, the study wasn't assessed to look at clinical points in terms of improvement in clinical symptoms and IBD. And so a current study called the UK Fargo study is currently underway, and those data are eagerly awaited. Many of you might want to know what to do about diet therapy. And this is a fairly limited area of study and limited to a single case report of a 13-year-old female with PSC and UC who undertook exclusive enteral nutrition for 10 weeks. And that did result in a resolution of abdominal pain and diarrhea and normalization of liver function tests and inflammatory markers, with an improvement in the radiology with the MRCP findings after a year. In addition to that, gluten-free diets have also been trialled in PSC in the gluten-free diet study. And this investigated the potential benefit of a gluten-free diet as well as an amylase trypsin inhibitor-free diet in PSC. Now, both gluten-free and amylase trypsin inhibitors are both proteins that are actually found in a number of processed foods and things like pizza and pasta, wheat, rye and barley. And this elimination of this diet for 8 weeks had no effect on clinical symptoms of PSC or IBD-related activity. However, once the patients underwent the diet, there was a reduction in their pro-inflammatory markers as well as markers of scarring. So this points to the potential role for a gluten or dietary compound in IBD-PSC development. But at this stage, based on these data, we wouldn't be routinely recommending such a diet. I'm now going to switch tack to the risk of bowel cancer in IBD-PSC and the need for surveillance. And first of all, take a step back to remind you of the risk of colon cancer in patients with inflammatory bowel disease without PSC. And we know that patients with chronic IBD are at increased risk of precancerous changes, which we refer to as dysplasia, and colon cancer around about 8 to 10 years after their diagnosis. This risk appears to be greater than the general population, but it's still overall low. And what we do know is that with improved treatments of inflammation and better technologies for early detection of precancerous change, we're likely to lower this risk over time. But what about more specifically the risk of colon cancer in IBD-PSC? Well, what we know is that IBD-PSC colorectal neoplasia, in other words, dysplasia and cancer, so in other words, precancerous change or cancer itself, is more common in the right colon of these patients. It tends to occur earlier in the disease course of patients with PSC IBD. And the IBD-PSC colon neoplasia occurs at an increased frequency compared to those with IBD alone. The scary thing for us as clinicians is that IBD-PSC colon dysplasia, or that precancerous change, can be invisible to our naked eye when we do colonoscopy and only picked up on random biopsies. And so what I will say about IBD-PSC is that it is associated with a high risk for the development of colorectal neoplasia, either precancerous or cancerous change, and therefore requires yearly colonoscopic monitoring. In terms of quantifying that risk a bit further, this was a study out of the States by Shavadi and colleagues. And what they did is they took a whole bunch of patients who had inflammatory bowel disease and followed them over time and looked at and compared the outcomes of those with IBD-PSC in the blue compared to IBD alone in the red. And you can see that at around the 10-year mark, the risk of developing bowel cancer was just under 2% in those with the IBD alone and reached up to about 6% in those with PSC IBD. How can we actually prevent colon cancer with any medical therapy? Well, one particular drug that you may be familiar with called ursodeoxycholic acid did show conflicting results when trialled compared to placebo at low dose. It was found to be associated with a lower risk of precancerous change. But in a separate study that you can see on the right, when used at high dose, those who actually went on this ursodeoxycholic acid had an increased risk of development of colorectal cancer. So the role of ursodeoxycholic acid for chemo prevention or prevention of cancer is unclear and is currently not recommended. So how do you go about decreasing your risk of developing colon cancer if you've got combined PSC or IBD? Well, maybe if we better control the IBD, you might be able to reduce the risk. We know that IBD medications don't increase the risk, but it's actually it's difficult to prove that they actually do reduce the risk. And the other thing to say is that it's important to undergo yearly surveillance by colonoscopy, and we use some techniques such as dye spray to try and improve our ability to visualize the lesions. You could see that on this left side, it would have been very easy to miss the lesion. That's more easily highlighted by the use of dye on the right side. So I'm going to touch on some of the future research in the field. I think it's critical that we try and unravel the underlying mechanism causing PSC-IBD and the interaction of the gut bugs, immune system and genetics, and explore the safety and effectiveness of microbial and immune therapies on PSC-IBD progression and impact of tight control. Try and identify biomarkers to detect early disease and disease activity, as well as undertake studies that really involve patient co-design in order to better understand the impact of PSC-IBD on patients' quality of life. So just to summarise, PSC-IBD has a unique clinical presentation to inflammatory bowel disease alone. We know that the gut-liver axis and gut microbiome have become increasingly recognised as a therapeutic target in PSC. And vancomycin, the antibiotic, appears to be promising, but further trials are required. We know that fecal microbiome transplantation is effective in UC and requires further evaluation in PSC-IBD. And we also know that PSC-IBD is associated with an increased risk of colonic neoplasia, either precancerous change or bowel cancer, and requires proactive surveillance. And with that, I'll finish my talk. And again, thank you, Kerry and PSC Support Australia.